My name is Rodney Rohde. I'm here to moderate. It's a pleasure to moderate for Dr. Gerald Redwine. At the end of the session today, you probably know the drill, but when I'm done and when Dr. Redwine is done talking at the very end, we'll have hopefully some time for questions. And at that time, I'll also give you the code for your continuing education at the very end. You can do that online, which is nice. And you can also go in and rate the evaluation and things like that also later. Our speaker today is Dr. Gerald Redwine. He's an associate professor at Texas State University in the CLS program. His primary areas of specialty are clinical chemistry and body fluid analysis, and his particular research area is type 2 diabetes mellitus. Dr. Redwine recently completed his PhD in 2015, so we're very proud of him at Texas State. And that dissertation had a focus on diabetes mellitus and how that resulted in the development of an actual theory, a new theory, and learning model for African Americans. His research interests now focus on developing that theory and for the distribution of information to reduce that disease in African Americans. His hope is that others will expand upon the theory and learning model through its use in further research. I think you'll find Dr. Redwine's talk interesting. It is a qualitative research in nature, so if you've not experienced that, I think you're going to enjoy kind of his story behind his research. So let's welcome Dr. Redwine.
I thank all of you for attending this session. It's very important to me for the African American community. I thank ASCLS for allowing me to do this presentation because it is very important, I think, for the African American community. So I'll start out by asking you this question. What would a model for reducing diabetes in the African American community look like? Well, this is the focus of, that is the focus of this presentation today. As you might well know, diabetes is the 7th leading cause of death in America. And in the African American community, that prevalence of that disease is greater, so the urgency to reduce the diabetes occurrence in the African American community is great. So from this presentation, you should be able to learn a little bit about the advantages of doing qualitative research, the advantage of doing a particular study of qualitative research called grounded theory, and in reversing the trend of diabetes in the African American community, you should learn two prevailing characteristics of African Americans and the dominant institute that must be involved if this reduction is to occur. And also you're going to learn some modeling exercise that you can do to help prevent diabetes. I am thankful for CLS doing a focus series last year on qualitative research. You can go back and look at this. Dr. Susan Campbell, who is our incoming president of ASCLS, is one of the people that was on this study. From this, I extracted a couple of things that is salient to my presentation, and that is from a quote from Miriam talking about what qualitative research is. Qualitative researchers are interested in understanding how people interpret their experiences. And being grounded theory, which is one of the qualitative research models, is interested in a method that understands the theory that explains the phenomenon of interest, that being diabetes for me. And also according to their research, that the data is anchored in the experiences of the individual. And that's important in qualitative research in developing a theory because it must be grounded in the participants' understanding of what's going on. So I want you to know I did not set out to do an African American study about diabetes. I wanted to do diabetes in general, but I did a literature review, and the way I got to where I'm at is through the literature review. It directed my study. I found out that diabetes is considered an epidemic by the American Diabetes Association, and they predict that in 2050, 1 in 3 Americans will contract the disease during their lifetime. Now, this is in 2050 for the general population, but for African Americans and Mexican Americans, that prevalence is in existence today. 1 in 3 during their lifetime will contract that disease. That means, by statistics, there's 5 million out of the 39 million African Americans will have that disease in their lifetime. So, important to this study is understanding why a study for African Americans is important. Based upon the statistics by the 2010 census, there is 72% of Americans are white, and only 12.6% is African Americans. This number flipped from Mexican American and African Americans as of the 2000 census that's done every 10 years. But if you would notice, look at the prevalence of the diabetes in the African American community. 13.2% of the African American community contracts the disease. Now that number is really less than 1/3 of what we have in the white American community. Only 5 million, but it is the prevalence of that disease in this community. So the problem is not on the economy of the number, because it's much smaller. But the problem is within the ethnicity, there's a great prevalence of that disease. I learned during the literature review that for this community, if you're going to work with this community, group support is important. Group support meaning exclusivity with that ethnicity, whether it be African American or Mexican American. Working with them, they feel more comfortable in talking. And in fact, in order to do a qualitative research, you must have the individuals talk. They must trust what you're saying, trust that you're not going to violate their trust and misrepresent them. And so, in order to develop a theory, I needed people to talk. So, I found out also within this African American community that there are subdivisions of that community. And that subdivision is based upon churches. They are divided up on that. But I want you to see the statistics here. As of 1910, according to Summit, 90% of African Americans live in the South. What's the problem with that? Well, South being ex-slavery, 90% of African Americans from that community, and there was a 44% of illiteracy. Today, even, there's a great number of illiteracy, but the only authorized institute during that time was the churches. And because of that, that's where they sought their development, both for survival, for both physical and spiritual survival, as well as educationally. And that institute became an institute that the African American community trusts. So if you're going to do the study with the African American, you have to work with the churches, is from that research. To show you how prevalent that is, even in 2008, Lugo did this here survey, a very extensive survey that you see here on the culture of religion in America. And even in 2008, 88% of African Americans associate with some form of organized religion, 88%. And of those 12%, 75% of them believe that the 12% that do not affiliate with any organized religion, 75% still believe that religion is important. And that's in comparison to 34% of the rest of the population who do not affiliate with any organized religion. So that church becomes important. Again, like I said, there is a further complication when working with African Americans, even with churches, because churches are divided up into denomination, and each denomination, trust me, is different. And they have their own beliefs and philosophies, and it goes back to these two individuals back in philosophy, whether they understand it or not. Calvinism and Arminianism is the way they are divided, and those are two different philosophies that keeps the churches separated. For African Americans, there's basically 4 churches that dominates that community. So one of them being, the number one being Baptist, Number two would be like Pentecostals. And within that, those are, you have Methodists and others that are in there. My upbringing was from the Pentecostal, and so if I'm going to work with African Americans, I'm going to get them to talk. They have to have some trust in me. Since my background is in Pentecostalism, not there now, but that's where my background was. That gave me some clout into that with African Americans. So working with them, there is this here denomination called Church of God in Christ. I am not currently a member. I started independent church, non-denominational, but still I was ordained elder in this, so I went with this. Because look at this number. This number is, there's 5.5 million African Americans that's in the Pentecostalism. If you look at this number in comparison to the number one sufferers of diabetes being the American Indians and Alaska Natives, their entire population is only 2.8 million. But this organization has more than that, more than twice that, in that particular denomination, and 6.5 million worldwide. So I figured that was a good place for me to start. I had the background knowledge in it. So in the literature, what I found, there was not a theory that discusses the social constructs and the spirituality that influences those with diabetes, those that suffer from diabetes. And so what I saw the need for was to fill that gap with a theory to understand this population. So I chose a methodology that would lead me to the development of a theory to understand this population in order for me to work with them and others to work with them. One of them was the main theory that I used was grounded theory methodology that was started by Glacier and Strauss back in '67. Further work was with Corbin and Strauss, who worked on this even up to UC to 2008, and they promised with this theory that you would have that with grounded theory, you are able to produce a theory that is explainable, interpretable, and applicable, and then from the observation, you're going to be able to extract the theory. So I trusted this as a model to use for developing a theory because that is what is needed in the African American community, something that is concrete. They further said that it does not take a genius to develop this theory, but what is needed is someone that has a different perspective from the campus. In other words, what's out there now, you have to have a different perspective from that in order to be able to see beyond what is going on to develop this theory. Okay? So, based upon my literature review, I learned that there was a prevalence of diabetes mellitus in the African American community. The culture to study it needed exclusivity. There was subdivision, and I selected a major division in order to study, and you have to be familiar with the culture, which is why I went that direction. So I decided to use my experience and develop the theory through inductive reasoning. So, EMIC is simply an insider perspective. So I approach this from an insider's perspective because I am African American, I do have diabetes, and I have familiarity with the culture, and my firsthand knowledge goes back to 1888. Firsthand meaning that this is my dad, believe it or not. Born in 1888, I am his 14th child. When he was born to him when he was 70 years old. He still had 3 more after me. But my upbringing was in the country. I'm a country boy from the farm, and I'm from the sticks, from the hicks. I'm a hick from the sticks. I might as well admit it. I just happen to be one that made it to into this level of academia. But I came straight up off of the farm, the Jed Clinics. If you know the Beverly Hillbillies, that's us. But in either case, I grew up, my literal growing up. I know it can be embarrassing to some, but that's okay. That's my background. I have that type of perspective. Growing up plowing with a mule. That's how we grew up, on a farm. planting crops, raising those pigs and those kind of things. I have that as a background, and my mom, who was 40 years younger than my dad when he married her. He had a 6th grade education. She had gone to college at Prairie A&M. I have those things, those type of perspective, and some things that we have in common with, I have in common with my mom, is both of us have diabetes. My dad lived to be 97. My mom only lived to be 62. So I have those dynamics as planned. I have those perspectives. I have the background on those. And so I figured that gave me an insight on developing this theory. This is my grandfather over here. He was born in 1851. And not my great-grandfather. This is my grandfather. He is an ex-slave. I have this theoretical framework that I use, which you have to have a theoretical framework for developing a theory. And this came from Afrotheism, meaning that African Americans who are ex-slaves develop their own peculiarities that still are in existence today. It's a combination of being ex-slave and Christianity mixed. Things that influences my theory: social cognitive theory by Bandura. I am a constructivist, meaning that I believe that the environment that you're in helps you to formulate your own thoughts. So what your background is, it will help you to formulate your own thoughts. And so understanding this here, symbolic interactionism, things that's in our culture that gives us an indication of how we're going to respond, is important to understand that. So that was the first thing I had to try to develop. Before I go on to that, I would like to show you, this is a deed that was passed on from namesake, the slave owner, H.D. Redwine. And if you will notice here, I know it's hard to see, but he passed us on my great-grandfather, which is as far back as I can go, Levi, born in 1831, and Henry, who was born in 1851. But he passed them on to his children. The ironical thing is, this was in 1864. Well, 1864, if you know about the Emancipation Proclamation, it was declared in 1863. And it's not like they didn't know it. It was over because Raz, who the son is, he was a general in the Confederate Army. So I'm sure they knew the war was over. Well, maybe they don't think it's over now, but I'm from the South, so I knew that a lot. The good thing about it, I don't know why they love these two gentlemen so much, but this 1,000 acres that was passed on to the children was given to my family, and we still have ours. My dad still have his now. That's still in the family. About 3 of us still have that. They also donated land for the church that I grew up in down in the country, which is still there. They donated the land for that church and helped build it. So I use some sophisticated software in developing my theory, and these are a couple of those that was there for developing the qualitative theory. It takes a lot of work and time to do that. And these are the participants. I had only 5 participants. I know in quantitative analysis, we have to have a lot of data, but in qualitative, you need only a small amount. These 5 participants produced over 200 and something pages of documents of writing. It is very in-depth and detailed to go through these. These happen to be the ones, these 3 were the ones that was, had a diverse background, as you can see, a retired nurse, CNA, and a common laborer. These have been in the church that I studied, the COGIC, it's pronounced Kojic. And these 2, number 4 and 5, Carlos and Nick, these were the role models. These are the ones that had gotten diabetes under control, and that was important for my study to see what their perspective of this was. And all of those, by the way, are pseudonyms. Those are not their real names. But I know them so well, I still call them that. I know their pseudonyms better than I do their names. The first thing I said was about the symbolic interaction. And I had to draw that out, and I drew it out not from whole cloth, but from their data, from what they said. And what I found out is that there was a vision I have to be mindful of the time. The vision of top, up and bottom, positive and negative, but there was promoters of things from their perception that helped them to understand what diabetes was and helped them to reduce the prevalence of diabetes. And then there was distractors from those things. And then you had the one side was more positive than the other side. So you had 4 different sections, in other words. But they were divided up into those that was mentors, that was positive role models and things that helped them to control diabetes, including doctors and nurses. They looked at these and clergy as mentors. But those same ones you can see down here could be distractors from when they use hegemony, which is if they're hegemonic practices, which is domineering practices, they would be negative. And then on the other side, there was things that they thought was negative, such as fear, that did help them with managed diabetes, and that was the threat of diabetes itself and medicine, but those help control it. And then you have this one, which is feast, that were socially acceptable and good and enjoyable, but they was poor for managing diabetes. This is just one of the programs. This is just one of the texts from all of the transcripts that all of the interviews had to be transcripted, word for word, and what you see is a bunch of complexity of how I use this to get precepts, and then I use the precepts to get categories to see where everything fit in. And this is another program that I use for diagramming, memo writing, all of that. It took months to develop this theory. So what did I find out? So here we are to the good stuff, the stuff that I really want you all to know about. I found out that I could distill everything into 5 different categories of what these individuals was experiencing. Fear, faith, fear, fix, frustration, and fatalism. And there are 3 different processes that they went through: actions, interactions, and emotions. But this one, for fear, for example, for the African American community, for these African Americans, in order for these individuals to be stimulated to change and grow, fear was a great factor in that. Why? You have to understand historical background of slavery. Man, it just takes a lot to get their attention. Distrust, a whole lot of things that goes into that. And then just a lot of African Americans, just life struggles, just trying to make ends meet. So these things, diabetes tend to be a secondary thing, and as important as it is. But when fear did happen, I found out that there was the fight or flight situation. Fight was to lose weight, things like losing weight, to try to fix the problem. The flight was to say, you know what, whatever, just give up on it. Okay? And then you had some threats of like eyesight loss, kidney damage, and those kind of things also cause fear to stimulate one of these situations. So that you understand that I didn't just make these up, and to hear how I got these, hopefully these will play. Here's a sound bite about fear. This is from Carlos. Okay. Okay. That didn't work. Alrighty. I don't have that sound bite. That's unfortunate, but we'll go on. Yeah, we'll just press on. All right, so sorry about the soundbite. Those sound bites are important for this here to see what's going on. But in either case, there's two people that dominates when it comes to diabetes, that dominates the thought of the African Americans that I studied, and that is doctors and pastors. Those are very important, and both of them can have a positive or a negative role. Each one of them. Most of the time, the pastors were more nurturing and was fostered motivation, even if it was through fear, and saying you need to take care of this or however they did it. They respected that, they learned, and then they would try to fix the problem. But also they could go the opposite way, where they're domineering and just get them upset and cause them to go into fatalism, where they just give up. So you can go either way, and you have to be careful with these individuals. Doctors could do the same thing, but most of the time, the experience of these individuals, the doctor was just demanding, just said, do this, do that, give you a pill, and out the door you go. And that frustrated them to the point of just saying, what's the point of this? I found out through these individuals that their social construct based largely upon ancestors that they use as experience with certain diseases. They use them as mentors. They brought it down to fear, and they compare what they had to these individuals, and they could go one of three different ways. Here again, you see the fight or the flight. But also there's a third way. They could just get an understanding. And faith here, I found out, was simply this: what they believed about the disease, what they believed about how they can control it, what's going on with the disease, and they could use that as a precautionary, and it sort of stimulated the direction that they would take in the future. Now here we have some information that is very crowded here, and I know it's a lot of information, but these are coded, and this sort of bring out the qualitative in me, because I coded all of those, all of that data into these complex things here, but notice they were still in these 5 categories: faith, fix, frustration, fatalism. And then there was things that connected faith to the fix, fear, frustration, and fatalism. And these are the number of the prevalence of these. So here's the bottom line. I said I need to put this in a concept that I can visualize, and that is where the theory came out. When I put these by numbers, faith was the most dominant. This again is their psychological understanding, their spirituality, their faith. It was the most, and it went in the center. Fix was the most positive, and fatalism, and those two are actions. So you have 2 actions: fix the problem or just give up on the problem. You had 2 emotions: fear or frustrations. The arrows tell you the direction that they would go, and the highlight of these arrows, the density of these arrows, tell you the numbers of these. And if you would notice that the one that was positive here was the solution, the fix, and between fix and fatalism. You can't see it up here so well, but if you notice Nick and Carlos, these was one that had diabetes under control, and they focused on fixing the problem. This happened to be an area of self-efficacy where they understood what was going on and they knew they had it under control. The rest of them focused on what they believed about the problem. So I had this model to come up like this, and let's see if I can get the audio, if he can. This is Livia, and if you can hear her voice, you can hear the connection I made between faith and frustration, and suspicion and solution. So here is solutions, here's a suspicion. You can hear all of that in the audio. Let me see if he can help me out here. I want to do this one right here. That's just a bit. If not, that's okay. I'll just. Okay, we're going to press on. I also found out that, again, Carlos gave, this is a good example of what I mean by self-efficacy. The focus on the fixing the problem and the connection between what they believe and the solution of the problem. I also found that there was 4 quadrants that they could have. These are the most positive. This is the best scenario here, where they operated between fixing the problem, fear of the problem, and what they believe. This is the most positive outcome. The least positive was the focus on frustration because of complications, and even like getting medicine or what the doctor would say, and even like gyms closing, that they can't do the exercise anymore, those kind of things frustrated them, caused the complexity that was less positive. And then you had the less negative and the most negative, but all of the negatives focus on fatalism. So I looked at this model here and I said, this looked familiar to me. What pulls these together is what I call substantive living. And what that means is that these individuals, without the audio, what they focused on was trying to be able to enjoy their life. That's substantive living. These individuals want to enjoy their life. We can understand that. We want to enjoy our life. And so that motivated them as to what they wanted to, how they approach this particular disease. This substantive living was something that connected all of these together, and in order for them to be able to manage the disease, what would have to happen is their particular paradigm and in other words, their thought about this needed to be changed. How did you change this? You change this by what I call permeated learning, meaning that the individuals had to learn, but they had to have someone that helped them to learn about a particular disease in order for them that they trusted, in order for their paradigm to change. In order for them to change, they needed someone to help influence their decision. And that decision came through these particular ones. The ancestors helped influence that, but more importantly, the pastors would help them to say, you know what, I need to reevaluate what I call substantive living, what I value. And those, again, the pastors and the doctors can do the opposite, which is frustrate them to cause them to give up. This is a photo I looked back in our family archive. This is my dad when he was about 21 years old, around about 1910. This is my grandfather, the ex-slave here. The important thing about this photo is the fact that these individuals worked very hard. For example, my dad farmed, and I told you when I was born, we were still farming. That was when he was 70 years old. But notice, they also took time to enjoy life. They played baseball. This is an old Negro league. I haven't ever looked it up to see if hard hustle was one that was ever recognized. But this is a Negro league, and in spite of the hard work that they did, they still enjoyed life, and it had to do with physical activity. Now, I said my dad lived to be 97 years old. He worked. When I was born, he was working. When I left home, he was working and on the farm. And my brother, just a couple of weeks ago, said that he could tell that he was slowing down when he was about in his early 90s. But he was still out walking. He said, well, we would take the cattle from one pasture to another, and I could tell he was getting older because he was just going slower. My point is this: no obesity, always worked, physical activity, and had a picture-perfect health. So that told me that I have a legacy of health. And what has to happen in the African American community is, to some extent, a way of producing more activity. I'm scared to even try this, but I had some exercises that I had learned, and Professor Ellis has done a great job of editing this, but I'm not sure if it's going to work. But either case, but I found out, based upon what the interviews were saying, that the participants were saying that, listen, sometimes the facilities would close down and change and stuff like that. And so I said, you know what, there has to be a way of doing things that without having to pay for a facility. And I remember back, and I've been using these exercises in order to help me control my diabetes since I developed this in around 2014 when I was working on this. I've lost about 15 pounds, and I mean solidly, and I have my diabetes under control by just doing these exercises, some sit-ups, stretches. I will see if some of this will work. I don't know. We tried it a while ago. Everything worked, but nope. All right, so we'll just press right on past this. Okay, so here's what we have from this qualitative research using grounded theory. Well, we found out that there are some characteristics that has to be taken in control with working with African Americans with diabetes. That they're going to fall into basically two categories. They're going to either look at fixing the problem, or they're going to just give up. And you have to be careful with them and interviewing them and talking with them in order to encourage them to go one way or another. There is the actions that they will take. The emotion is fear or frustration. Basically fall into those two categories. I didn't find any others that could not be put into these categories. And their control center or their psychology is what they believed about it. And the number one that they needed was pastors, and probably number two is doctors to understand this model in order to encourage them toward managing diabetes. And finally, they need whoever is going to work with these individuals need to work through the churches, and which means the pastors, in order to encourage them for loss to manage their diabetes. That just happened to be a fact. So these are some things that I want to work on in my research, and presented this here theory to those that are stockholders, such as those in churches with diabetes, but mainly pastors. And that's the aim of this, is to work with them. This is the last time I'll do the full presentation. From now on, I will focus on what will work on reducing diabetes in the African American community. I do need people that work with me on the research. I'm seeking grants to do these things also. I apologize for the audios. Those were very important to this, and they were working, but that's just a part of the presentation. So, do we have any questions? I think I'm on time. Yes, sir.